All right, good morning, everyone. Thank you for joining.
All right, we are going to go ahead and call to order. It looks like we have a quorum nice and early this morning. So thank you everyone for being in person and online joining us today. Shelley, if we can do roll call, please.
Sure. Alyssa, Michael. Andrew Kang.
I'm here.
Thank you. Tony Griffin. Brent Forget. Brian Stevens. Charles
Here.
Jones. David Natrika. Debbie Johnson. Ed Dickinette. Rondo Tramarin. Gail Bradley. Present. Garth Gamer.
Present.
Herman Butler. Iman Feiserkan.
Present.
Nick L. Nara Patel. Rod Reed. Brian Southward. Sandy Nygaard.
Present.
Solomon Boger. Helen, are you able to give us a verbal? Sarah Johnson.
Present.
Vicki Bennett.
Present.
Did you get Brent Forget? And it looks like Dr. No Treat is on there too.
I'm here. Sorry, I missed my name. Sorry.
Not a problem. Thank you. All right, just a reminder to everyone, the audio and recording is going, so everything said and shared in the meeting does become part of the permanent public recording that is shared to the Bureau's website. This includes anything that is in the chat as well. So thank you for everyone being here today. In terms of the attendance report that is in your packet, just a reminder that if you missed 2 or more consecutive meetings, the Bureau will reach out to you to see if you're still interested in serving on the committee. Again, thank you everyone for your attendance here today. So we wanted to do a quick acknowledgement. Number one was just to acknowledge Debbie Johnson, who has served on our committee for 20 years. Marissa, you are off mute there.
I have so much proof. I had to do everything by the book, by the Mormon book. That was because that was the truth.
Okay, sorry about that. Anyhow, I wanted to acknowledge and recognize Debbie Johnson, who has been a member of this committee for 20 years, and she has announced her retirement. So, not the first committee, but many of our committees with the Bureau for so many years. So we appreciate that and wanted to give you just a little plaque and acknowledgement. And thank you for all of your years of service and participation. So there you go. Absolutely.
Can we get a photo of you before you leave?
Sure. All right, so, and because of that, we now will have a vacancy, which is a representative from a statewide rehab facility. So, I know that someone has been earmarked, but I just officially wanted to say that. But thank you again for all of your participation over the years. For anyone whose term is expiring or has expired in January of 2024, please let Shelley Thistle know if you would like to continue with your participation. Her information is on the agenda. There's copies outside the door. If you did not get one, you can grab one, and that has all the information that is necessary. In your agenda packets, we also have the 2024 schedule for these meetings, both the statutory and planning committee meetings. So if you have any questions about those will be available as well. I will turn over to Marcia for the bureau report next.
Right. Well, good morning. It's so good to see so many people in person today, especially Debbie. Congratulations on your retirement. We are going to go through the bureau report. We'll try to do it relatively quickly because I think we have a pretty good solid agenda today. We have some slides that will tee up. Before we go through the slide deck, though, I would like to introduce our newest staff members. In the room with us today, we do have David Hansen, who joins us as part of our naloxone Leave Behind and FR grant program. He comes to us with quite a bit of experience and a law enforcement background and working on FR grants work previously. So thank you for joining us. We're looking forward to working with you. We also have our GIS guy in the background, Mike Hamilton, who comes to us with some really solid EMS and GIS mapping experience. They both told me that as the day goes on, we can introduce them as the math guy and the Narcan guy. So thanks in advance. We'll introduce you a couple more times today. So we have the bureau slides, and Shelly, I'm going to ask you to help us skip around on them really quickly. We do have an EMS and trauma system overview slides that we will share out with everybody today as part of your meeting packet. Moving on though to our other updates in 2024, we wanted to let you know that we did receive an appropriation for this fiscal year of roughly $4 million. We slid over $800,000 of that budget off the top to go out to our EMS regions, our 4 local EMS coordinating systems in the north, south, central, and western areas of the state. And those funds currently are going toward training and education. And specifically, we have earmarked $100,000 in each region each year for rural paramedic education. We want to thank you guys for all your work, especially in the regions, getting those funds out. We also wanted to start sharing our top priorities as we enter 2024 in the new year. Happy New Year to everybody. I will not go into these priorities in great detail today with staff, but as we make it through our agenda today with all the other committees, we'll be talking about the strategic planning process and how we will engage both EMS and trauma stakeholders in finalizing our EMS and trauma strategic plan, as well as a needs assessment report we've been working on. Moving through these though quickly, I'll skip over this, but Julia's going to talk about our strategic planning timeline and other work with you all. Please know that by the time we get to September, we are going to be bringing back to the State Trauma Advisory Board both the needs assessment report as well as our strategic planning priorities for review and adoption. Our goal is to have that available for review by the September meeting. And then going on, I'll give just a few quick updates on legislative and rulemaking stuff. So we have up here some info on the 2022 and 2023 sessions. We wanted to make sure that we are still providing information, of course, on House Bill 2609, as well as some of the bills on appeals in 2023, so that stakeholders are aware of the new legislation that has most recently gone into effect in January. There are also a couple EMS-related bills that dropped in 2024. The department at this point has not done an extensive review whatsoever of the bills you see up on the screen. In 2024, there are certificates of operation, House Bill 2290, and behavioral health transportation is another bill, House Bill 2066. So we will be reviewing those at this point, though we do not have any official position or anything to share yet as we start to take a look at what has dropped. Of note, and we'll talk about this in the next slide, is the bills that you see starred there from the last couple of sessions do require that the department does rulemaking to establish rules for some of those new laws that went into effect. And in our next slide, you will see our rulemaking update. The last 3 bullets there are pending rulemakings for this year. You all know we still have that ground ambulance rulemaking package pending. This year, we will also be working on our EMCP certification and training rules, as well as EMCP scope of practice. So that's what we have teed up for this year, and we look forward to working with the committees on those. Going to our next few slides. I will not cover these right now, Shelly. We can skip ahead to slide 20. And we'll come back to those for the rest of the groups later today. Next steps in the rulemaking process are outlined here. We will be this year developing state standards for critical care paramedics and emergency medical responders. We also will be reconvening our rules work group to outline what interfacility transport reporting requirements will look like in our state. Of course, we will keep our committees updated on when we will have our next upcoming rules meetings. Beyond that, I think, Shelley, I'm going to go next in our agenda to, do we have Carissa or is it Julia?
I think Chris on the line. Chris, are you there?
Yes, good morning.
Good morning.
We just wanted to give everyone an update on our trauma registry system. So we're currently at the beginning of our RFP process to obtain a new trauma registry system. We anticipate posting the RFP before the end of this month. We've been working with our procurement department. We expect to complete the RFP process by July 1st of this year. And then the goal is to have the new registry system implemented at the state level as well as all of our trauma centers by July 1st of 2025. So if anyone has any questions, feel free to email me on that.
Thanks, Krista. Any questions from anyone in the room or online? Next up, a share update. Julia?
Good morning, everyone. So we are in the final stages of transitioning the share AED and theater registries over from the University of Arizona to ADHS. We have completely transitioned the AED registry over, so we have a new URL for that at aed.adhs.gov. And we're currently in the process of testing a similar site for the cardiac registry for hospital. So we're currently testing that and have a tentative launch date proposed of early February. We'll be sending out communications to all the hospitals with updated login information. At that point, we'll be able to be again working the EMS hospital data, and then we'll start working on 2023 share report. If you have any questions, please feel free to reach out to myself or Adam Rodriguez.
Thank you. Next on the agenda, we have a link to some data visualization and falls. Vatsal, are you online?
Yes, I am. Can we, instead of that, I have put the updates in the slides. Shelley knows.
Okay, excellent. Thank you.
So last STEP meeting, we were asked to do the comparison between the trauma and non-trauma centers, okay, for HDD ground level, hip injury, and what was the outcome. So what you see over here is that one side we have hospital discharge database analyzed for ground level falls, and then divided them into ground level falls and falls from height. And on the another side, you can see that the analysis is done from Arizona State Trauma Registry falls. Well, in the first table, it's comparing all the falls and divided into falls from height and ground level falls. So the distribution between the trauma registry and hospital discharge database is kind of similar. Like 70% of the falls are ground level falls. Even in trauma registry, I think we are just zoom in a little bit. No, other way around. So we can see the side-by-side table. Yeah, it's both the side. It is a 70%, whether it's a hospital discharge or trauma registry. Ground level falls makes up 70% of all the falls cases. Then the ground level falls were further divided into ground level falls with hip injury. So what we saw is that in the hospital discharge database, around 5 to 7% between that or the ground level falls resulted into hip fractures or a dislocation. Whereas in trauma registry, we have a slightly higher percentage between, that's around 12 to 14% is the hip fractures are recorded in the trauma registry. Can we scroll down a little bit, Shelley? Yes. Then the further questions we wanted to figure out was the difference between the non-trauma centers and trauma centers for the ground level hip injury, and what was the difference in the outcome between the trauma and non-trauma centers. So what we found is, if you see the non-trauma centers, and the trauma center, the distribution is like trauma centers tend to see very high numbers of ground level falls with hip injury, 66% cases, whereas trauma centers, only 33% cases were ground level with hip injuries. And when we look at the outcome, non-trauma center, the fatality for the ground level hip injury is around 3%. In 2018 to 2022 data shows 2.7% fatality, that first line. I don't know if you guys can see or not, but that's the either died or went to hospice. Whereas in trauma center, the fatality is somewhere around, between 4%, in a range of 4% fatality. So there's a slight change, but it's not that significant change between the fatality between non-trauma and trauma centers. So that's for the falls. What my plan is, I'm intent to basically update the falls dashboard based on the feedback I have received from a few of the last few STEM meetings regarding what they would like to see for the falls. The dashboard will be updated pretty soon, comparing both hospital discharge database and trauma registry discharge database on the falls. So, any questions on this?
Yes, thank you. A
Hey,
question,
Vasu. Hi, this is Andy Tang from Tucson. When you compare the non-trauma versus trauma center admissions, are they matched? Are they comparable in terms of injury burden?
No, they are not. It's just the name of the facilities. If it's a trauma center, then it's a trauma center. So yes, it would be still a possibility is still there that they are not entered into the trauma registry as trauma cases, but they were treated at the same trauma center.
I understand that, but you don't have further statistics on, their injury severity scale, for example. So
Hospital discharge database does not collect injury severity score.
Sure.
Dr.
So
Jones.
it's possible that the folks admitted to non-trauma centers are less severely injured compared to the ones coming to the trauma center, which is what we hope and expect.
That is true. And, I on top of my head, I don't remember, but we have done that analysis to compare the injury severity score between the trauma and non-trauma centers. There is what was the metrics name, but there's a metrics name available, which helps code the diagnosis codes and to give us the injury severity score. So I have done that research project many years before, where we can figure out the injury severity score in the hospital discharge database based on the diagnosis codes. There is a Johns Hopkins University has done some research on that. We certainly, if this is something is interest, we can talk about it and we can do the further analysis in detail. That will require a lot of in-depth analysis to do that, King, but there is a possibility to figure things out.
Okay, thank you.
Dr. Jones.
Yeah, thank you. That's great work. Cliff Jones, orthopedics representative. I think the stratification is very important, but I think the other one that would be very helpful is going to be age. Knowing that, over the age of 65, you would have a 30% 6-month mortality just statistically concerning that. And I think with our era of, during COVID, 30% of people left healthcare, resources at trauma centers versus other centers. I think this is interesting work concerning hip fracture, because a lot of times that gets into pelvic ring at the same time as a diagnosis. And looking at this data would be very helpful. As a great example, like one of the largest changes or things that you can do to reverse preventable death is sending a pelvic ring injury to a level 3 center instead of a level 1 or 2, just again because of expertise and resources and so forth. And this may be something also to take a look at for these hip fractures. Again, that's a global term of do community hospitals, non-trauma centers do a better job with these elderly patients or not? Especially if there's a weekend component where people sit around, knowing that after 24 hours, again, your mortality goes up greatly for hip fracture. So I think this is great work. I'd like to take this offline and see if we can kind of splice out some other data from that if we can, because I think that's very important, especially for EMS services who, have hip pain or, pelvic pain. And this may be a better way of getting patients to the right center for the right treatment. And maybe they're all the same and it doesn't matter. But I think having this data is very, very important going forward. So I thank you for your work concerning that.
Thank you.
Thank you. I mean, those are some of the excellent points you mentioned. I mean, would you mind emailing me all those points which you would like to see it? I can try to cover some of the basic descriptive kind of things in the dashboard, but some of the statistical things which you were mentioning, maybe we can try to see if we can create a different report in depth analysis, which is kind of not for the public, but we can do it for the staff part. But I would really appreciate if you can send me all those points and email me.
More than happy to.
Yeah.
Thank you. Yes, next.
Hi, Tammy from Deer Valley. One of my questions, and this might be related to kind of what Dr. Tang was getting to, and maybe I just don't know. Are these patients that are being presented, are they identified as like an isolated hip injury? Or is there a potential that these patients, especially those going to those higher level trauma centers, is there a potential that they have head injury involvement as well? Just looking at the death rate between the two, you would assume your death rate would be less in your trauma centers versus your non-trauma centers.
So this hip injury, the ICD-10 codes I received from the hip injury was from Sean Barker and Vicky Bennett. I worked with them to figure it out which one they would consider as ground level hip injury cases. Those are the ICD-10. I'm happy to share the ICD-10 codes included in this table. And obviously, when we do the final report, the methodology section and everything will have all the details you guys want to know.
But I think to the question, to clarify, Vatsal, if someone has a current head injury along with a hip fracture and just had a low GTS on your trauma center, they would still have the ICD-10 code for the hip fracture. So they would likely end up with a higher mortality risk because of the other injuries as well, but would be identified as this, correct?
That's true, and we can identify those cases. I can separate it out by the head injury, try to see what is going on. And if again, these are all the points I need to understand from you guys to figure it out how we want to shape this report. So I appreciate, just email me and I will try to figure out different scenarios and different tables so that, we can finalize this report.
Thank you. And I see, Sean, you have your hand up.
Yes, so just a couple of comments. Vicky and I really took a deep dive into some of this, and Vicky added in the comments that we found in the review with other facilities that not all have reported and not all are reporting the same way. So there's a real opportunity for education for the registrars and for all the centers, for all the trauma centers, and how we capture that information and how we capture those patients. Then also, I think, Vatsal, you can help me understand this, but my understanding is the hospital discharge database captures all the patients in all the hospitals. So there is some crossover, I think.
Oh, definitely, yes. So let's go back to the first table, Shelley. Okay. And if you can scroll, yeah, perfect. So when I say, let's say in hospital HDD falls in that table 2022, we have 199,000 total falls, whereas in trauma registry we have 34,000. These 34,000 are included in that denominator of 199,000 falls cases. They are just not linked together, but definitely they are included within it.
And I think that is a really important thing when you look at the overall number of falls, and then you take out what is actually in the trauma database, this much smaller percentage there. That's something that each time we present this data to this group, we get more questions, which is great. And something we can maybe consider for our May meeting, just so we didn't have it, is we could potentially look at forming a work group out of staff in the future agenda item to really address the specific population. I think that might be helpful to have a subcommittee meet and really look at what type of data do we want to produce, because Boxel and her team are amazing at how they combine the data. We get data from several different sources, and it's great that we keep having these conversations. So I think that's something I'll add to the agenda for our next meeting, to do a subcommittee that can really kind of get together and look at how can we figure out what data pieces we want to start adding to this. Does that sound good to the group?
I love that idea, Dr. Bradley. I think it would be really important to look at things like comorbidities such as osteoporosis in these patients, because those are patients that are not typically captured in the trauma registry if it's an osteoporosis defining fracture. So it would be really important to look at that and our opportunities for preventing fractures in the first place.
Yeah, I mean, we hospital discharge database have very limited information they collect. So we will have some limitations over there, but we can definitely look into it, the way to improve this or way to further analyze this report. And Dr. Tang, if you also would like to please email me your comments, I will try to see what we can do.
Boxel, it's Vicky. Again, appreciate the work. As you know, Sean and I tried to dive into this, and we found a lot of inconsistencies for two reasons. One, the Arizona Trauma Registry inclusion criteria is different from the National Trauma Data Standard. So most of our facilities with the American College of Surgeons do collect TQIP, and there is a different inclusion criteria. So I think trying to dive a little deeper to see how we can make sure we're comparing same populations, apples to apples, for whatever we can, rather than having all these different variances. It leaves a lot of questions as to how we can have confidence in some of the data to make some decisions on. So thanks for being willing to work with that and continue to strive to dive into it a little bit more.
Vicki is Cook Jones. Are the national standards compared to the state standards more rigorous or not?
Well, the National Trauma Data Standard requires us to enter all of the hip fractures, which we do. That's not necessarily true for the Arizona, which is, I think, why we have some discrepancy of submission, because in some registries, we say this is not a state patient, and so it's not submitted. Whereas what we found, and Sean, correct me if I'm wrong, is that others were just submitting the same population that they submit to TQIP. So they were not segregating them out because they are different. So I think there was a different process and workflow that others were following, which I still think we're probably underestimating the total. By including the hospital discharge database, we are capturing some, but I also think we're missing some that may be contributory to the mortality and things that Dr. Tang and Tammy even alluded to with multi-system injuries, and Sean with comorbids. So I think there's a good start here of a lot of things that we can dive into, but I do think there is an opportunity to better define and look at it to make sure we're inclusive of all the different variables.
I agree with you, Vicky. Shelley, if you can just scroll down a little bit on that report, I can show you. Okay, yeah, that's good enough. So if you see the ASTR ground level falls and hip fracture and dislocation, yes column, they are in the range of 2 to 3, around in a 3,000 range. 2022 data has 3,000 ground level hip injury cases. Now, if you look at the table in hospital discharge database, there are around 8.8 to 9,000 cases of in each year. And of those, like if I stick to 2022 data, 9,000 ground level falls and hip injury. If we look at the table which is below that, Shelley, little bit, which divides into trauma and non-trauma center. Trauma center has around 5,700, but in trauma registry, what we saw is around 3,000 cases of ground level. So there is an underestimation in trauma registry for sure.
Vicki, do you think from this committee, which is very multidisciplinary, that again with a subcommittee component, that we should make recommendations to the state for level 1 status that you collect data similar to a national registry to kind of get us up to date concerning that, because this is the old adage, you can't manage what you can't measure. And if we're under measuring what we're doing, then it's a problem for us to manage these patients and determine how really well or poor that we're doing. And maybe that's just a wish, but I think, if this is a state department, then, and we're looking at public health, this may be something that I don't know if we need to make a suggestion or get inroads to kind of, push that at the state level, because we're clearly a little different. What we call level one here is not level one nationally, where we kind of wrap into level 1 and 2 centers. And again, if we're a state agency with some public health component, then having this data may be helpful. It's a little more onerous, but that's why you're level 1 status. There are expectations of you when you're level 1 versus a community hospital.
Yeah. Yes. So I'm going to go ahead, Vicki, and just kind of, I think that's a great wrapping up point. And then, so what I would say is the goal of this committee is a trauma advisory board. So certainly to advise where we want the trauma system to go. I think a subcommittee that could really have addressed this. My goal, we would need to officially form the group in May. What I'll commit, I know people schedule plan far in advance, is Shelley and I will look at a schedule to do something in early June. Hopefully before people are all gone for the summer, to get a subcommittee together. I think coming back with recommendations to this when we get ready to do our annual report, which is published typically in to this committee for approval, that would be a great time to make some recommendations. The rule writing process, we have to get permission to open the trauma rules, and certainly those things to be discussed then. But having that recommendation from this board would be a great first step. I think that from a standpoint approach, we'll commit to scheduling that subcommittee in June. We'll get a date as a kind of save the date, and then we'll officially work to approve forming that board with the May meeting. Let's see, Boxel, did you have another link to data visualization of trauma injuries by year to share?
Sure. I mean, it's there on the second slide. We can go to the actual dashboard. I don't have time to go through the actual dashboard, but just give you a few, can give you the few points is that 2022 database has been added to the dashboard. Yeah, we can go to the snapshot. What we added some of the features over here. Can we do the 2022 year, please? It's a 2017 year over there. So we have almost 6 years of data now available for the comparison purpose. We just select the year, and then the statistics will change based on the year you select. We have total 68,000 cases of trauma for the year 2022. It gives information on the snapshot. Actually talks about the top mechanisms of injury, what was the mortality, mechanisms of injury in the pediatric and geriatric populations, and some of the risk factors. So it just gives you a little overview of what's going on with the trauma in Arizona. A couple of points I want to highlight. If we can go to top, I will show you the still on the up. Yeah, let's go to the demographics. What it shows us, it's from 2017 to 2022, the number of trauma cases are increasing. And you can also see the trauma incidents by all the demographics by county, race, ethnicity, and gender, age group. But what we added over here is that we have added 2 filters on the top. And one of those are the trauma center designation levels. So you can look at it level 1 or level 3 and 4 are combined because of the sample size. But if we want to look at it, the real trauma or a high severity cases, you can just choose level 1 and see what's happening with the level 1. And under the age groups, we have given 2 populations, pediatric and geriatric. So we can have the pediatric report right over here or the geriatric report and see what's happening in that population. So those 2 filters were new and were added in this dashboard. So you can see the things, how the numbers changes. Yeah. And then we'll go to trauma mechanisms. Can we go back to, it will be, say similarly over here, this shows us basically trauma mechanisms. Number one mechanisms is falls, followed by motor vehicle traffic occupant. So and if you can we put a mouse on during the falls, and then yeah, that's on the fall in that red box. And when you put up, it also again shows you number over the years how the falls are increasing, from 2017. So any injury, basically you scroll a mouse and then it will show you the statistics for the last 7 years together. Just obviously you can select the year and also it will the number change, but it just gives you a visualization of all years together. On your right hand, that bar has a lot of information available on each of the injuries. Right now it is about that. What it says is what is the mortality, hospital charges, drug and alcohol use, hospital admission, what percent were admitted to the hospital, and what was the median length of stay. If you click on any of the injury, everything changes, and you can see for the particular injury. So let's say this chose struck by against, and then it, yeah, even though it will show you the mortality, how many deaths happened, and then the charges, and for struck by against, what is the age and gender population, and how does the race and ethnicity look like. Can we click again back to the struck, so it will struck by against? Just click on that, or yeah, and no, double click on that. So I want to double click on fall. So yeah, so now it goes out, then you come out. Okay, again, we have a trauma center designation on the top and the age groups on the top if you want to select and see specific. Yeah. I think that's fine. We can now move to assaults. This is a new page we added in the dashboards. And this gives you that number of assaults are increasing over the years from 17 to 2022. There are 4 main mechanisms of injury in assaults. Assaults are intentional trauma. So the 4 main mechanisms of injury are struck by against, cut, pierce, firearm, and child and adult abuse. One of the things which we observed in the mechanism of injury is, even though struck by against is the number one mechanism of injury for assaults, it has been decreasing over the years. If you see that, yeah, that's the case. It's been, though still the number one, but it is decreasing over the years. And what we saw is that the number of firearm injuries are increasing from after COVID. We saw that increase in the number of firearm injuries, whereas child and adult abuse and cut and pierce are kind of at the same level over the years. And then it gives you the distribution by, again, the demographics. Let's go back to the top page. We have a transportation to the hospital. It talks about the air and ground ambulance and privately owned vehicle, and same type of transportation for each of the county. It shows the distribution. So in some of the counties, there are more air transports compared to other counties, and some counties we have seen the pattern of more privately owned vehicle compared to other counties. So that's a distribution by county. And then the air transportation by urban versus rural, we can see that it is more in the rural compared to urban, which is perfect. That's what we want to see. And then the transportation by injury severity score, we want to see higher severity and more air transport, and that's what we see. Yeah, that's it. And then we do have a trauma center map in the end.
Thank you, Bhaskal. So just a reminder to everyone that this dashboard is kind of our new way of doing the trauma annual report. And so as we get further questions, we keep updating these dashboards, we being Bhaskal, and really add things when the committee brings things forward they'd like to see, even if it's not necessarily at our time frame to update our annual report, we're able to make changes and have included some of the changes that were requested at the previous meeting in September. So thank you everyone for your participation. Again, if you need the link to this, I think the link is live in the agenda. So you can go look at this and make some adjustments to review that data on your own. We're going to move next to the standing committee report. I'm just going to ask the reportees to try to keep a very brief summary if you can, just because we still have a full agenda of items I'd like to cover.
Hey, David.
And just a reminder, if you're not speaking, just please keep yourself on mute. Sean, if you can give us TEPI updates.
Hi, everybody. TEPI meeting was a very good meeting, and we had we were able to establish a quorum. The minutes were approved as presented. Chief Garcia presented slides to discuss the House Bill 2609 response time reporting for EMS, and that work is ongoing. And shared resources available that are posted to web pages for AZ peers, NEMSIS version 3.5 topics. Dr. Bradley gave a share update. Dr. Bradley also presented dashboard data for motor vehicle trauma. I think Bothell was part of that as well. And then there was discussion about drug and alcohol use and the need to adjust to add fentanyl results. Then Dr. Bradley also shared dashboard data. There was discussion about hip fracture data, as you saw today, that's being captured better. But due to hospitals being designated or not, there's a difference in reporting, and much of the data can be captured in the hospital discharge database, but it's not as specific as the trauma registry data. And that's it for the TEPI report. Thank you.
Thank you. Next up, Sandy for education.
Yes, good morning, everybody. Our minutes were approved as presented at our November 16th meeting. The group did discuss the EMR curriculum. Of course, it's not a voting item yet because it has been clarified. There'll be upcoming in rulemaking. The group also discussed the critical care paramedic and endorsement curriculum. That also is not a voting item at this time. PED seizure training was approved as presented. It is now posted on the website. PEDS airway training is approved as amended, and it is also posted. The group agreed to a second workshop meeting for fall prevention training, date to be determined. And after reviewing the list of training modules, members voted to form a work group for sepsis. Matt will review offline hands-only CPR. Amber will review the online Safe Sleep Brewery. And the volunteers for sepsis were myself, Brian, Amber, and Raquel Munn. And that is the end of our report. Thank you.
Thank you, Sandy. Next up, Franco for PMD.
Thank you. Can you hear me okay?
Yes, thank you.
All right. So PMD minutes and bylaws were approved as presented. Bylaws were amended, slightly improved. At that point, we discussed a new curriculum for emergency medicine responder, and that was discussed. As well, we discussed the critical care paramedic endorsement curriculum. We reviewed the T3G for behavioral health alternate destination. And then we also heard a presentation on adding antibiotics to drug table 1. That motion did not pass. And so that motion failed to carry. That's it for PMD last month.
Thank you. Heather for ASTR.
Yes, so our last meeting for the trauma program manager workshop was in August of 2023 at FMC. We went over some falls, some burns, some ATV accidents with Arizona Game and Fish expert and got some state updates. Our next trauma program manager workshop is on February 23rd, in Phoenix Children's, and that's all we have.
Thank you. Next, Brianna for Pages.
So PACES is welcoming individual for our vacant position of pre-hospital coordinator. If you would like to apply, please forward your CV to myself or Adam Rodriguez. Additionally, PACES and the EMSC are offering the didactic portion of the NRS training, and I will be happy to provide that registration link in the chat. Lastly, the Education Committee has approved the pediatric seizure training as well as the pediatric airway management training. And those are now available on our State Department website. And we welcome you to attend our CP meeting coming up on March 21st at 1:30 p.m. And that concludes our report.
Thank you. All right, next for discussion action items. If I can get a motion to discuss the method approved the meeting minutes from September 21st. Thank you. Is there a second? All right. Those were in the meeting package. Any recommended amendments? There are none. Anyone opposed to the meeting minutes as displayed, please say nay. Any extension? All those in favor say aye.
Aye.
Next, we have, I think, covered up some of the follow from the annual report. So thank you, Bothell. Dr. Patel is at the executive committee for the DOT today. So he said he will have a meeting at the next meeting. So we will defer item C. I will hand it over to Julia for our launch of the Trauma Program Recognition Awards.
Sure. Thank you, Dr. Bradley. So as you all may be aware, last year we had our first EMPT of the Year award. So we were able to provide 4 awards to EMPTs from around 8. And this year we're really excited to be able to add to that by adding on a trauma award component. So we worked primarily internally to develop some criteria for different awards. So we actually came up with a list of 8 awards. I should have shared that with Shelly. Yeah. Yeah, that'd be great. So the information is currently posted on our website in the full for inspections. But essentially, some of the categories that we have for the trauma awards include Trauma Program Manager of the Year for each level, Trauma Medical Director of the Year. Get there. Here's the list. I think we have an Injury Prevention related award, Trauma Registrar of the Year, Research/Academic Achievement Award, and then a Pediatric Champion Award. So we have many categories from which to choose from to nominate people in, but we're really excited to be able to do that this year. So the nomination form is live. It's posted on the website and also will be included in the slides as part of the bureau reports, and will also be sent out via gov delivery probably sometime today. So we're asking for nominations to be submitted by March 15th, and then we'll have a committee review those and then be able to provide the awards at the staff meeting in May.
Thank you. So we are very excited. This will be kind of in honor of EMS week and recognizing all the work of the trauma community. Nice to do those awards. The Bureau is not going to be involved in this kind of vetting of these who gets the award. So just that everyone knows we are not part of that, but we are excited to get these going. Yes, Gabriel?
Is this meant strictly for activities in 2023? That kind of how, or is there a timeline? Because I can think of someone who recently retired that might be a pediatric champion.
I don't think there's any specific time frame in there. It just will have to go through the categories and then the committee would review.
Shelley, you wanna? Sorry. Oh, you ready to go back? Never mind. It's okay. There were several questions on the submission form that can kind of guide the thinking process. But yeah, there's no specific requirements as to when achievement occurred or anything like that.
I misspoke. Didn't retire, just changed position.
Oh yeah, I think that's fine.
And like Julia mentioned, that will go out by a gov delivery, and in the gov delivery communication, there's more information about the committee that will vote on these and also kind of things to consider when nominating someone. Before we go to this one, I just want to cover, I'm going to go a little out of order on the agenda and just quickly discuss reporting on fentanyl use / ingestion as part of ASTR. So this is something that I think many of you are aware of, is fentanyl crisis in the United States. Currently, this is something that can be reported, but had not really brought up specifically in looking at your trauma data with ASTR submission, and specifically looking at not just the general drug screen and drug use, but looking specifically at fentanyl ingestion, as we know that this does affect many of our trauma patients. And so we wanted to discuss, ask the committee, the group's thoughts on how to get that messaging out. Again, this is a kind of a voluntary thing, as was mentioned in the chat previously, related to fall injuries. At least right now, we can't make ED changes to our data registry, but we do want to at least say if something is optional, we'd like to try to encourage people to collect that data, just because of the fact that we are in the fentanyl crisis. So wanted to get feedback from this committee and to talk about how to spread that message within your facilities of trying to collect that data. Yes.
This is one of those that I think that the more data you have, the better, obviously, but the hospital discharge data might report fentanyl use, and then the trauma registry might report
So the issue is that facilities are not reporting that to either. So they are not often testing for it. So many facilities routine drug screen does not actually test for fentanyl. So depending on your facility, you actually have to test the same urine sample, but you have to test or put a separate order in. So for many facilities, it's 2 separate orders to actually test for that. And so the issue that you see with many patients is that that's not even being tested for. So it's kind of a lack of even having the baseline data, number one, being collected, and then number 2, being reported. So certainly if you don't collect the data, you're not going to have it to report. That's kind of problem number 1. Problem number 2 is there's no requirement currently to report that specific subset. So really this is just trying to get the messaging out of, as a trauma community, do we want to say as a recommendation that we want people to try to collect that data, as we know is a metrics opportunity. And we have heard questions from legislators about this. So I don't know if we're going to see legislation or not, but it has come up. And not just in regards to trauma, but in general.
They asking specifically for fentanyl overdoses or just opioid in general overdoses?
So right now, I think just any positive drug screen. Carissa is the expert, so she can correct me, but it's not specifying. If you're going to come up on your drug screen, it won't necessarily show that it's fentanyl. So you have to actually order that separately. Yeah, it's a big issue.
And like my question with that is a lot of times like you don't order a urine drug screen. Patient arrives with an opiate overdose. A UDS is not going to change anything that we do. So like, are they satisfied, quote unquote, with like diagnosis of suspected opiate overdose, like appreciated overdose, or are they wanting us specifically, like if the question like in the department, they want us to switch over and do specifically urine drug screens? I think those are 2 different apps in my mind.
I think that's part of the discussion to have is how you collect that data. I think right now we're really not getting it either way. I mean, there's always the fundamental thing. Do you get an alcohol level? But most trauma patients get an alcohol level, even if they're 90-year-old for ground level fall. We're getting an alcohol level as a standard, but we're not getting a urine drug screen, fentanyl screen as a standard. So we know that that's probably an equal effect in our trauma population, if not greater. One of the questions that we've started asking, members is, if you screen separately for fentanyl, I mean, how is it going to change, your approach to treatment, the protocol? I mean, as opposed to just sort of general opioid use. I mean, is it, especially if it's abuse, not just normal use? So, I think that the short answer to me is when I look at that is that many patients now who have a chronic opioid use disorder are only using fentanyl. And so when you screen them with a routine drug screen, they're going to have a negative drug screen and won't be identified as having an opioid use disorder. Okay. So the issue is that you aren't going to identify it unless they self-identify, or there's something else that comes in state that it was a fentanyl overdose. Okay. So that's kind of the big issue, is that unless there's other indications or self-identification, a negative urine drug screen kind of makes it seem as this person does not have an opioid use disorder. Okay. So what is the cost associated with fentanyl specific UA? I'm not sure, Matt. We'd have to check on that. It's probably facility specific. It's the exact same time frame. It results with the regular drug screen. So it's no different. It's just some facilities have started making this part of their routine drug screen. It's also typically part of a routine OB and pediatric drug screen. So typically when you order a drug screen for pregnant patients or pediatric patients, the fentanyl is included in that because they want to have that data for that patient population. And that, I think, is where we have heard questions about it tied to maternal health. So I think, that's where we do know that data is very easy. There's no increase time frame to get that result. It's just a matter of pressing it. So good conversation. I wanted to just bring this up as a starting point to kind of put it out there as something to consider of how do we get that messaging and making sure that we're correctly identifying this patient population to help get resources to address the opioid crisis.
Where do you want to take this from here? Do you want to?
So there's really, unless someone were to tap, something that gives us the ability to open rule currently, this is one of the things that we can, again, make an advisory. So these are things we want input from the committee as what kind of information would we like to see in our trauma program moving forward for the state of Arizona. Is this a benefit? Do people think it's a benefit or not? And then how do we move forward with that? So just something I wanted to plant the seed in the discussion piece. I know Carissa has discussed this at TRUG. I'd asked her to bring it up with that committee, and she has brought it up there as well. And so hopefully just getting that discussion started will start to see a little bit. But, you know, definitely getting the engagement for this group of supports.
Well, far be it from me to advise a huge fiscal impact on our healthcare system, but I can't help but think that just getting a baseline fentanyl on board for a traumatized patient is useful. And then you can take that in a number of different directions regarding etiology of trauma, mortality related to fentanyl on board. And it's all in demonstrating to the public what a terrible problem this is. And it seems to me that we could be the tip of the spear in doing that.
And we do know that if you can initiate medication for treatment, that certainly the patients have much lower mortality risk. And so I think there's data to show that we can decrease mortality from recurrent possible fentanyl overdose if you can initiate medication for treatment. And with the new TA rules, you don't have to get the X waiver now to do Suboxone. So I think we can actually have an intervention to decrease mortality. But again, you have to identify the patient population to do that. Dr. Jones, you had a question?
Yeah, sorry your team and late us on a quick call there, but it is interesting that, 10 years ago, as a trauma committee, number one cause of death in 18 to 44-year-olds was trauma. Number one cause of death now is fentanyl. 18 to 44. It's pretty shocking. But in terms of a little off from that is going to be meth, and meth does affect me as a population very much in the fact that it interferes with interleukins. So your infection rate is markedly higher because you have no immune system when you're on meth. So it does affect how I take care of patients when it comes to drug screening. It also affects how we take care of patients with a trauma resuscitation. Patients that are on meth don't need more fluids, they need epinephrine because they have no catecholamines left. They're kind of completely depleted. So I've had many instances where I'm coming in to take care of an unstable pelvic ring injury, and it's not really their unstable pelvic ring injury they're bleeding from, it's the fact that they're hypotensive. They have no catecholamines to keep their body up and going again. So, some of these drug testing that we do does, it's not only, boy, how many does this guy have, 5 or 6, but it does affect our treatment of our patients quite a bit. And again, 10 years ago, this was not as it is today. And today I can't tell you how many patients come into that, doing anything from being on the job, driving Uber. I mean, it's pretty shocking to see those numbers. And it does affect how we direct our patients in terms of their treatment. Fortunately and unfortunately, both.
Thank you. I think it is a great discussion that we really are capturing, I think, of many of our trauma patients with data. And then, we're seeing this in all age groups. Certainly the 18 to 44 is more common, but I've seen 75-year-olds who are also using substances. So we know it's a huge issue. So just wanted to get that conversation started with this group so we can really try to encourage collecting that data to help guide our trauma system. All right, I'm going to go turn it over now to Julia and Adam. We wanted to engage this group with our trauma and EMS needs assessment strategic plan. We have had multiple stakeholder sessions. So for those of you who have participated, I think Chief Ells, you've heard this a few times, but thank you for listening again. This is going to be a little bit more focused to the trauma centers. I will turn it over to both of you.
Yeah, awesome. Thank you, Dr. Radley. Yeah, this is definitely a different set of questions that they did presentation, but you've heard this already. So hopefully it'll provide some additional information and insight. Just want to note that we would like to gather a little bit of feedback via plan. So if you wouldn't mind either typing this link into your phone or computer or capturing the QR code to get you to the survey. That is where we will be asking questions today. So just quickly, today's objective, we don't have a ton of time this morning, but we wanted to quickly review the Bureau of Strategic Planning process, review some of the needs assessment survey data that pertains specifically to trauma centers, and then use Control Everywhere software to help identify some strategic planning priorities. So just a quick overview of our strategic planning process thus far. So ultimately the end goal is that we will have a strategic plan in place in January 2025, a 5-year plan. So we're hoping that later this year we'll have that plan drafted and we'll be able to share with the EMS Regional Council and Statutory Committee. But currently we're in the listening and learning phase. So last year we conducted the survey needs assessment and did some focus groups. And so we're kind of continuing that in this year to help us continue identifying priorities and strategic plan. And then it's a quick strategic planning timeline for this year. January and February, we're hoping to develop a finalized needs assessment survey report so that we're able to share all of the information that we've been sharing at these various groups in a more condensed way, and then also develop some county and regional profiles so that we're able to supplement that information. In April, we're hoping to host an EMS and trauma strategic planning summit in person so that we're able to provide an additional avenue for individuals to provide feedback in the planning process. By September, we're hoping to have a draft strategic plan ready for review at EMS Council and staff. So we'll present that to you then. And then around the November-December timeline, we would like to publish our 2025-2030 EMS and trauma system strategic plan for implementation in January 2025. So I will hand it off to Adam for the trauma center responses. I would like to say the trauma center responses were part of our organization assessment, so that was sent out separately than our individual EMT assessment. We did get around 21 hospitals, which we acknowledge it's not every single hospital, so we have to look at some of these results, just understanding that it's a small piece of the puzzle. But just keep that in mind, and we would love to see any questions that you have about the presentation, and then also we hope that you are able to provide some feedback to your course.
Thanks, Jules. So zooming in on those trauma center responses, we have the 21 respondents. This is how they break down per their level. Level 1 was the largest, followed by level 4 and level 3. This is the breakdown about the service region on the left. This is asking the hospitals, the trauma centers, where their service covers. And so this is a select all applied. Some hospitals are in a position to cover multiple areas. And then we also broke the respondents down by their role within the hospital. We thought it was very important to target the right people. And so the majority of respondents were trauma program managers, thank you, followed by EMS regional coordinators, medical directors, and down.
Moving on.
This is the first domain we're looking at is workforce and staffing, and we just have some really basic questions about workforce and staffing towards hospitals, and that is, are you experiencing a challenge with staffing? And the overwhelming majority indicated that yes, they are experiencing some level of shortage. The next slide will illustrate, we asked them on a scale of 1 to 5, how bad is that for you then? And we see that mean there. Most respondents indicated that they had some moderate impact. When we pried about workforce and staffing a little bit more, we asked them about recruitment and retention. What did you believe your organization is having experiencing? Why do you believe your organization is experiencing staffing challenges? And the top answer there is looks like recruitment, lack of compensation or incentives. Retention, lack of compensation or incentives to retain the workforce. So they seem to feel like retention is a bit more of an issue, but then right there in second place is recruitment effort as well, and so it seems to be on both sides of that. Thank you. We were curious to see what percentage of the workforce from these respondents whose workforce has had specialty certifications, giving more ability to the hospital, and we see a spread there. We asked this in terms of percentages, rough percentages. Do you think about 25%? Do you think about 40% of your staff has carried additional certifications beyond the requirements? And so that's a spread for specialty certifications amongst workforce and staffing. We asked about subspecialist coverage. We're very aware that in rural Arizona, in distant hospitals, that coverage is a lot of the reason why EMS is interacting with these facilities as far as interfacility transfers and things like that. And so we wanted to poll about these subspecialties and the ability to cover these physicians to cover some of these. And so again, the overwhelming majority was that they are experiencing difficulties with these types of specialty coverages. We'll take a moment and pause. If you reflect to your Poll ED Everywhere software that Julia had you take a picture of, we can put the QR code back on the screen. But we want to know strengths, weaknesses, and changes regarding workforce and staffing. And so You can respond on poll EV, although it's not limited to that. Please discuss this. Please put it in the chat, whatever means you'd like to. But this is just a good way for us to capture that information to act on. So you should be seeing those questions. Are they seeing all three of them or just the first?
Yeah, all three.
Okay.
So the top where if you use the QR code, these questions will come up. You can input your answers and then that gets recorded into our data collection as well. We're also happy to take any verbal feedbacks from the group if you'd like to provide anything verbally too.
We'd also be interested in knowing if there are any additional questions that you would wonder about if we were to do a similar survey in the future. So if anything like that comes to mind, please feel free to share with us.
Julia and Kim, are we going to be posing the same or similar questions at the next trauma program managers workshop? I'm going to move forward a while before.
So those questions will remain up on your phone until we get to the next polling question. So if you haven't finished your response, then there's go ahead and do so. The next section is injury prevention. We asked about collaboration between hospitals, about injury prevention programs, and things like that. And so what is bold at the end of the question, that is the response, that's who is answering the question. We asked of level 1 facilities, how frequently does your trauma center collaborate with level 4 trauma centers on public injury prevention and response? And so what's in bold is who is answering this question. You see the frequencies down there. Some facilities don't collaborate, and then otherwise we see quarterly and yearly. This is the same question, but again, we're asking it, the respondents here are level 3 facilities, and we don't have any level 3s that aren't doing anything that in the respondents that we have. And again, we see the spread there between monthly and quarterly. We are asking level 1 facilities here, how frequently does your trauma center provide education and resources to level 4 trauma centers in the region? And again, it was spread between no collaboration, yearly, and quarterly. We asked, this is level 3. These are level 3 trauma centers responding, and how frequently they cooperate with level 4 regions, trying to get a sense of what kind of collaborations out there. And again, yearly and quarterly, monthly and quarterly. Some of these, some of the areas that we asked where they had programs in, follow-up transfer, stop the bleed, any of these public outreach topics, TNCC, additional certification, things like that. These were some of the responses. This is the response from a level 3 facility. How often does a level 3 facility collaborate with a level 1 trauma center on public injury prevention? Yearly and monthly. And the similar question once more, asking level 4 trauma centers how often they collaborate with level 1s. Yearly, monthly, and sometimes not at all. We asked about the funding. The majority does not have reliable sources of funding. The majority of our respondents, a few do. This gives us an idea of maybe their funding. Again, this is take a moment and type that in, or point your camera at that QR code and rank these. I think there's a little arrow on the left. There's 4 little blue bars or 5 little blue bars, and on the left there's an arrow. You can move these up and down as you see fit to rank them. Then it might not tell you if you submit. I think it just kind of sits there on that screen, so it might be a bit odd, but
Yeah, I'll just give like 30 seconds for anyone who's working on the previous survey to submit that before we move on to the next question. That's a couple surveys.
Oh, are they still working on the previous
Yeah.
question?
So when we do switch to this question, is there also another option to write in as
The
well?
next question after this. All right, you should be dealing with the question.
Okay, well, after you finish ranking these public health initiatives and then looking forward to our next question is there anything you'd like to see that we haven't mentioned? Is there one more?
Oh, no.
Okay, we're gonna leave the last one open for you to fill out as we look at this next section, which is a data section. The last section we'll look at, just a few slides here. We wanted to know what trauma centers' main uses of the data that you were collecting. And the top responses are there on the left: trauma quality improvement, injury prevention activity, and trauma care peer review. Some of the other categories you can see: research and development, public education programs and development. I think we had a right, was there an open, was that the other was for, was an open write-in at the bottom? Or whatever, there's just another to select.
Oh, yeah, if there were.
Okay. Looks like, I guess, like, one more. Oh, sorry. Sorry, look at the wrong screen. We asked if your trauma center, we were curious about any challenges to submitting the data. And there was one response to that challenge in that they had difficulties with obtaining registrar. Next slide. This is that challenge that respondent put down, that they were having difficulty obtaining certain registrars. And the last question for data that we asked, oh, sorry, that was it. Okay. Yeah, sorry, thank you, but there was more. The last question was, we'd like you to rank these priorities after we advance the previous question we were asking. We'll ask you to rank these in the same fashion you did previously.
And that is our last questions for this presentation, but there is a much longer presentation that includes more information from EMS agencies, and we'll be again compiling that to a report that we'll be able to share. So if you have any questions about the questions that we shared today or the process, please feel free to reach out.
Thank you, Julie and Adam. Yes, they have put together, there's quite a bit more information for those who've gone to any of the other presentations. The EMS agency and hospital version, kind of not focusing on trauma, is a much longer presentation, quite a few more data elements. So we wanted to give more of the bridge trauma-specific portion to this group. And this will also be presented as Trauma Program Managers Group next. Same presentation or additional data as well.
Maybe a few more.
Actually, data. The next, any agenda items to be considered for the next meeting, please feel free to email either myself or Shelley. We do have 2 items we will add, which would be the formation of a work group on all data and hip injuries. And then I think also maybe a discussion on substance use disorder and trauma as kind of an item for discussion further. Call to the public. In your agenda packet, you see the upcoming events. There's several listed. We also have listed activities on the Bureau's website. Our next meeting will be Thursday, May 16th. We will have both in-person and online option. And if I can get a motion to adjourn, please.
So moved.
Thank you.